Thank you very much. It's indeed a great pleasure and an honor for me to be here with you today. I hope in the next 15 or so minutes to share with you very quickly something on SARS-CoV-2 variants and their evolution, and I'll end off with what can we expect next. So I'll touch on the emergence of these variants, how are they being created, what are some of the worrying issues that may lead to their increase, and then end off with where are we going into the future. When we think back to when we first heard of the first public reports of this disease and the initial spread of what we've called the ancestral strain, sometimes referred to inappropriately as the Wuhan strain, very quickly, one particular mutation occurred at position 614. A conversion of D to G led to this particular variant becoming dominant across the world. But because it was so dominant and because it had been consistently dominant across the world over many months, we became somewhat complacent. We didn't really understand that this virus could lead to significant variants. But all that changed. On the 14th of December, the UK announced the Alpha variant. And shortly thereafter in South Africa, 3 days later, we announced the Beta variant, and our colleagues from Brazil, the Gamma variant, and our colleagues from India initially called the Delta variant a double mutant, and turned out that key aspects of the mutations of the Delta variant were consistent with a new variant of concern. We don't yet know what the next variant is. So how are these variants created? It should be pointed out that the virus itself has a slow genetic drift. We see in any of the variants a slow level of mutation, about 1 or 2 per month. And in each month, we have here in South Africa sequenced in the region of 500 to about 1,000 viruses, and we see these low levels of mutations. And this is the occasional genetic drift that we see. But we also see genetic shift. And these we have seen particularly in patients who are immuno-compromised, who have persistent long-term infection. And it's those individuals, particularly when they are on antibody treatment or vaccinated, we are most concerned about variants with immune escape. And there are many new variants being created, and most of them will just die off because they don't have any advantage. But to date, the WHO has described 4 variants of concern, 8 variants of interest, and there are about 12 variants that are just being monitored. I'll give you one example of how a variant could have been created in South Africa in one particular patient. We followed this HIV positive patient who was very severely immunocompromised, a CD4 count of around 8. In this particular patient, she had persistent SARS-CoV-2 infection for 7 months, that she was culture positive for SARS-CoV-2 over this entire period. She started off with a D614G variant, and over the course of those 7 months developed 11 new mutations, 7 of which in the critical important area of the receptor binding domain. At day 6, she developed the E484 mutation. At position 484, the virus and the ACE2 receptor are both negatively charged, and so they repel. But when a mutation occurs at that point, the virus becomes positively charged, and so you get very strong affinity. It's a key mutation for antibody escape. By day 71, she developed a key mutation as well that also helps in immune escape at position 417. And then finally, by day 90, she developed the 501 mutation. Those 3 mutations are the combination that makes up the key mutations of the Beta variant. So you can see how in an individual, she recreated the 3 mutations that make up Beta. And so we have for each of the variants, the different mutations. And I'm not going to go through it in this talk. I've provided it here just so that you can see the number of mutations in each of the 4 variants of concern. One of the big concerns that has already been touched on by Dr. Swaminathan so eloquently is the challenge that we will face because of vaccine nationalism that has led to poor countries not having enough doses to vaccinate their populations. And this vaccine inequity that has seen African vaccine coverage still below 5%, when globally vaccine coverage is around 50%, is creating an opportunity for the virus to spread and yet more mutations to occur. Let me go on to dealing with some of the impacts of variants and on the pandemic trajectory, and talk about what are some of the new variants we need to be concerned about. So here I'm presenting for you the first wave in India, Brazil, and South Africa. You can see in India, they had a very minor first wave compared to what we've seen in Brazil or even in my own country, South Africa. In fact, there were comments in India that they've conquered this virus, especially politicians making statements like that. But you will see in each of these countries that a variant has had a dramatic impact. In India, we saw the heart-wrenching pictures of the impact of the Delta variant, the shortage of oxygen, the challenges in hospitalizations, that just, everything was being overwhelmed in the system. Similarly, we saw the impact of the Gamma variant in Brazil. And in South Africa, we had our second wave driven by the Beta variant, and our most recent third wave driven by the Delta variant. Variants are playing a critically important role in defining the future of the pandemic. And here I'm giving you some example of how each of the three waves occurred in South Africa. And these are the sequences and the distribution of the different variants in South Africa. You can see how the Beta variant in the yellow very quickly, within a space of about 9 weeks, it replaced the D614G variant as the dominant variant. And the Beta variant itself was then replaced by the Delta variant, which, because it transmits faster, just simply outpaced the Beta variant. And so the Beta variant we haven't even found it now in South Africa for the last 9 weeks. So the Delta variant has now literally replaced Beta in South Africa. So we're seeing how transmissibility is impacting and determining which variants occur and how they replace each other. And now, given the transmissibility of Delta, that again, Professor Dr. Swaminathan has already touched on, that Delta now is the globally dominant variant. So why is it that Delta is so dominant? Well, because it's more infectious. And what drives that? Well, those who get infected with the Delta variant compared to ancestral variants have a viral load. The amount of virus that they put out in the little droplets when they speak, when they sneeze, is about 1,000 times higher. So in other words, the infectious dose that is required to cause infection is much more easily attained with a few drops. There's also those individuals with Delta remain PCR positive on average 5 days extra. In other words, up to 18 days compared to 13 days for the ancestral variants. Also, vaccinated individuals seem to be as infectious with Delta variant, although for a shorter period than unvaccinated cases. And finally, we have seen quite high rates of reinfection and breakthrough infection with the Delta variant. And the Delta variant is not a monolith, it's not one virus. There are many, many different sublineages of the Delta. And again, I'm showing that to you here in South Africa, how the multiple different forms of the Delta variant are now spreading across our country. So as we look at that, we're getting some sense of one particular sublineage, the AY4.2, which is rising rapidly in Britain and is increasing in the number of cases that are being caused by the Delta variant. We're seeing that similarly in Russia, and we're not really sure if AY4.2, or sometimes referred to as Delta plus, whether this Delta plus virus is really more transmissible than the original Delta. But those are studies that are underway and will give us some idea. But when we look at what is going on in the UK right now, almost over 100,000 cases per day, it's a reflection of the challenges even in the midst of high vaccine coverage. Let me tell you about another new variant, and that's Mu, which is currently a variant of interest. And if you look at the diagram on the left-hand side, you can see here the Gamma variant was dominant in Colombia. But what happened in the course of that, a new variant called mu in the blue started rising. Didn't become overly dominant, but it started rising and continued to rise over several weeks. And even when Delta, which is in the dark orange, started spreading and started literally rapidly spreading, you can see how mu has still maintained its dominance and has actually pushed even Delta aside. Now, we'll wait to see how that pans out over the next few weeks, but it's quite concerning when you look at these kinds of trends with the mu variant. And in these data on the right-hand side, mu is the blue in the last column, and you can see how much lower its neutralization titer is. Compare that to, for example, the beta variant, which is one of the most warring of all the variants in its ability to escape natural immunity or vaccine immunity. And certainly mu raises many of those same concerns, even to a greater extent. And we've seen how, if we're expecting the next variant, it may reduce and impact clinical efficacy of the vaccine like past variants have. If you look at the AstraZeneca vaccine, we have seen quite a drastic reduction in the efficacy of the AstraZeneca vaccine in the presence of the beta variant, from 70% efficacious against the D614G variant, all the way down to 10% efficacy only against the beta variant. And this is for any clinical infection. However, if you look at its impact on the Delta variant, it has maintained its clinical efficacy. Look, on the other hand, at the Pfizer-BioNTech vaccine. It has been able to maintain its efficacy against the beta variant. Those studies were done in South Africa. However, if one looks now at what we're seeing in terms of the breakthrough infections in patients and individuals who've been vaccinated with the Pfizer-BioNTech vaccine, we've seen a reduction, not a drastic reduction like we saw with AstraZeneca on the beta variant, but the Delta variant does have a lower clinical vaccine efficacy against the Delta variant for the Pfizer-BioNTech vaccine. So let me end off with just making the point that this is an unpredictable virus. So what can we expect next? Well, we don't really know, but let's use the information we have and plot out some possible scenario. So a best case scenario, I would argue, is where the virus is, just can't get any worse than what we're dealing with in the Delta variant. And so we're not going to see, major new variants of concern. And then we achieve high vaccine coverage. So we don't really enable the virus to cause many more new variants. And so we can expect that with that best case scenario, that we would go back to some level of normality with a low endemic transmission, and that we may need homologous boosters over time just to maintain high levels of antibodies. In a worst case scenario, we could see continual new variants, including immune escape. And that will be driven also by patchy coverage of vaccines. That's going to need ongoing public health measures, repeated waves of infections, and potentially heterologous boosters. Well, in one particular likely scenario, I would argue, recognizing that this virus is going to be with us for many years to come. Remember, it infects animals, so it can always come back. But that the worst most likely be behind us. So the one likely scenario is that we may yet see new variants of concern emerge, but we may only see one or two, a few more. And these may be included in the vaccine escape mutants. And so these may lead to a few more waves before the virus reaches a stage where it exhausts its ability to mutate without fitness cost. And this may need heterologous boosters and diminishing waves before we get back to normal. Now, it's very hard to predict what these new variants may lead to, but the one thing that's become clear from some of the modeling is that moderate immune escape is not enough for a new variant. It would have to have some increase in transmissibility itself to become dominant. And of course, vaccine makers are very busy with this, looking at how to make and design new vaccines to deal with what are called broadly the subecho viruses, the whole class of viruses of coronaviruses. But we must make no mistake, the variants have changed the COVID-19 endgame, that we are now dealing with a situation of vaccines versus the variants. So in conclusion, I'd like to point out that, we don't know, and the mutations of SARS-CoV-2 are unpredictable. How many more variants of concern we're going to see is still an unpredictable situation. That the 4 current variants of concern have emerged in the midst of widespread natural infection. And so they were able to evade natural immunity from past infection. But the next variants of concern will be emerging in the presence of widespread vaccine immunity. And so for them to reach dominance, they're going to have to deal with vaccine immunity, and so have to have some level of escape. And so the future trajectory will depend on waning vaccine immunity to some extent, on viral variants that escape vaccine immunity, and it's very likely heterologous boosters will be needed. And ultimately, in my view, that we're going to have to maintain some combination prevention strategy that not simply depend on only one kind of silver bullet approach. And so varying levels of public health measures may be needed as we go forward in vaccinated populations to continue to maintain some level of mitigation against the potential of new variants to spread. Thank you very much.
Well,